Hello and namaste. Welcome you all on the behalf of Department of General Practice and Emergency Medicine, Dhulikhel Hospital. I am Dr. Roshna Shrestha.
And namaste everyone. I am Dr. Anmol Shrestha.
So, in this online lecture, we'll be talking about anaphylaxis, a very important life threatening condition which we should be able to recognize promptly and manage very early. Let's go ahead. So, here are the learning objectives of this lecture. We hope that by the end of this session, you will be able to identify the clinical signs and symptoms of anaphylaxis, and then you'll be able to outline the initial management of anaphylaxis.
So the case scenario, we have a 24-year-old female who comes to our center with complaints of shortness of breath and dizziness. So what would you do next? So with almost all the acutely presenting cases, we go for primary survey, that is ABCD approach. So the airway, breathing, circulation, disability, and exposure should be assessed, and if there are any problems, we should be addressing the issues right at the same time. So let us see as the case progresses. So when we assess the patient's ABCDE, we find that the patient's airway is patent, the patient is able to speak. In breathing, the patient's respiratory rate is 35, and on auscultation there is wheezes, and the patient's saturation is oxygen saturation is 80% in room air. In circulation, the capillary refill time is more than 2 seconds. The heart rate is 130. The BP is 80 by 40 millimeters of mercury. In disability check, the patient's Glasgow Coma Scale is 15 upon 15, and the patient's RBS bedside blood sugar is 120 milligram per dl. On exposure, we find that there are multiple urticarial rashes over the back of the patient. Now, what is your provisional clinical diagnosis and the differentials? So, given the clinical scenario, by now you must have seen that the case has all the components that point us towards anaphylaxis. So, whenever we are clinically assessing any patient, so there are a few criteria which will tell us whether it is anaphylaxis or not. So let us think in three different clinical situations. In first situation, imagine that there is no likely exposure, or you don't know any exposure, any likely allergen exposure in the patient. In condition number two, there is a likely exposure to the allergen, and in condition number three, the patient gives a history of non-allergen. That is, in the past, the patient had similar experience with whenever he or she is exposed to a non-allergen. So, in criteria number one, when given that there is no obvious exposure to any allergen, the criteria is presence of sudden onset of an illness, which occurs within minutes to several hours, with involvement of the skin or mucosal tissue, or both. For example, generalized hives, itching or flushing, or swollen lips, tongue, and uvula. So that is the skin involvement, and at least one of these two conditions, that is either sudden respiratory symptoms and signs in the form of shortness of breath, wheeze, cough, stridor, or hypoxemia, or there is sudden reduced BP or symptoms of in-organ dysfunctions, for example, hypotonia, collapse, or incontinence. So, given that there is no proper history of allergen exposure, this is the criteria that must be fulfilled to say that this is a case of anaphylaxis. Now, in second clinical condition, the patient may have history of likely allergen exposure or trigger. So, in such condition, two or more of the following should be fulfilled, among which either the patient gives history of, or you find that there is sudden skin or mucosal symptoms and signs, for example generalized hives, itch, flush, swollen lip, tongue, and uvula, or sudden respiratory symptoms as described earlier, or sudden reduced BP or symptoms of in-organ dysfunction, or sudden gastrointestinal symptoms in the form of crampy, abdominal pain, or vomiting. So among these four, either of the two must be present. And remember that in children, sudden gastrointestinal symptoms are quite common as compared to adults. In the third clinical condition, the patient may give history of non-allergen, exposure to non-allergen. So in such condition, in case of infants or children, just reduced blood pressure may be sufficient to diagnose it as a case of anaphylaxis. In case of children or infants, the age-specific low systolic BP or decreased BP greater than 30% of the systolic BP. And in case of adults, systolic BP or less than 90 millimeters of mercury or greater than 30% decrease from that person's baseline. So always think about these three clinical conditions whenever we are going to diagnose it as a case of anaphylaxis.
Yes, and to add upon on Mo's statements, I would like to highlight that, see here, even the dermatological manifestation may not be present. Like whenever we think of anaphylaxis, we always think that the patient must have urticaria and other dermatological manifestations. But for criteria 2 and criteria 3, that may not be present. Please continue. Erase this out.
So as just discussed, just to summarize the clinical manifestations of anaphylaxis. So in respiratory system, there can be shortness of breath, wheezing, pharyngeal or laryngeal edema or rhinitis. In cardiovascular system, there can be hypotension or chest pain. In skin, urticaria, angioedema, flushing or pruritus only. In GI, nausea, emesis, cramps or diarrhea. And in neurological system, there can be headache or seizures.
So let's continue on to the case. So here is our case that Amol has already described. So based on that, let's think what are the life-threatening symptoms of anaphylaxis present in this patient and as a whole, and how would we manage this case? You can pause the video, think, and then replay when you're ready with the answer. So when we go to the algorithm, so first of all, we have to decide whether it's anaphylaxis or not. And Anmol has described it very clearly with the pictures. So if one of the three criteria are there, then we have to always think of anaphylaxis. And I again repeat that dermatological manifestation may not be present. And ABCD approach is must. So whatever the patient may complain or however they may present, so we approach with airway, breathing, circulation, disability, and exposure approach. And if allergen is still there, let's say for example, if the allergen was injection ceftriaxone or other drugs which we had just given in our ER and it's still there, the first and foremost thing is to remove the allergen from if possible. And anaphylaxis, like it can develop very rapidly and it can be life-threatening, so always call for help. So what are the life-threatening problems that a patient may have? So the most fearful is the upper airway obstruction, when patient will have swelling of the upper airway and it will be impossible to maintain the airway. To intubate the patient will be very, very difficult. The other life-threatening problem is lower airway obstruction. There will be severe bronchospasm causing to oxygenation problem, and then patient may present with shock. Okay, so these are the life-threatening problems that we should search for. upper airway obstruction, lower airway obstruction, and signs and symptoms of shock. So if they are present, we do not lose time. We give adrenaline IM immediately. Okay, and the concentration is same as it comes in our ampoule. It's 1 is to 1000 concentration, which contains 1 ml, and 1 ml is equal to 1 milligram. So adrenaline is number one drug, so everything is one. So we give it IM. Okay, in adults it's 0.5 ml IM. Where do we give it? We give it in the mid anterolateral thigh. Because studies has proven that the absorption from this area is rapid than from other areas. If it's a child, then we calculate it as 0.01 milligram per kg. So let's say if it's a 20 kg child, then we need, yes, so we need zero point 0.2 milligram or ml of this concentration of adrenaline. We do not dilute even in pediatric cases. We give it right IM stat. And then we reassess the patient every 5 minutes and we hope for resolution. After the adrenaline is given, we start oxygenation as needed. We monitor the patient and we start large bore cannula. And the first IV bolus of IV fluid, normal saline, is started at the rate of 20 mils per kg. So let's say if it was a 20 kg child, then we would give 400 mils stat. In case of adults, it's 500 to 1000 mils of fluid stat right away. If the patient has bronchospasm, as we discussed earlier, we can give medication to help with that. So first one would be salbutamol, as we give in any other bronchospasm. So 1 ml of salbutamol contains 5 milligram. We dilute in normal saline and give. In case of pediatric cases, it's 0.15 milligram per kg. If the bronchospasm is severe, then we can start magnesium sulfate. Okay, in adults it's 2 gram. We never give it bolus, so we dilute it, we infuse it with 100 ml of Namsan over 20 minutes. If it's a pediatric case, then it's 25 to 50 milligrams per kg diluted in normal saline. Okay, these are the medication we give if the patient has bronchospasm.
So let us continue with the case. Now, after giving all these preliminary medications, when you assess the airway of the patient, you find that the patient develops swelling of the lips, tongue, and the patient has some stridor. Now, this is the new development in the patient. So, what would you do next? You can pause the video and try to come up with your answer. So, in such cases, as you have seen that the patient has audible stridor, so there is an impending upper airway obstruction. So it is to say that even the repeated doses of IM adrenaline has not worked here. So in such cases, just to buy time before you are able to go for major airway management, you can try with adrenaline nebulization. 1 is to 1000, that is the form that comes in the ampoule, and 5 ml can be taken to nebulize the patient with adrenaline. In the meantime, the team should be ready with immediate with the appropriate equipment and team for immediate intubation, which can be difficult as the patient must have developed some form of upper airway obstruction. And in difficult intubation, we might have to go for cricothyrotomy if there is failed intubation. So regarding refractory anaphylaxis, that is to say, whenever there is even after repeated doses of IM adrenaline injection, we are not able to find any improvement in the patient's condition, we may have to think of IV adrenaline. And starting IV adrenaline is a is bit difficult and sometimes dangerous. So you may have to have your senior faculty present at the time when you decide for IV adrenaline. So the preparation, we go for a bolus dose or the loading dose followed by an infusion. The bolus or loading dose, the preparation is in the dilution of 1 is to 100,000. So for that, what we can do is we can mix 0.1 ml of 1 is to 1000 dilution adrenaline in 10 ml normal saline and infuse it over 5 to 10 minutes. However, please remember that in pediatric age group, direct IV bolus is not recommended. So once the loading dose has been given, then now we go for IV infusion. The preparation of IV infusion is 1 microgram per ml. So for that, we need to dilute 0.5 ml of 1 is to 1000 adrenaline in 500 ml NS normal saline. So we go for a continuous infusion at the rate of 0.1 to 1 microgram per kg per minute, which is titrated upwards to produce to see some effect. So this may be a bit cumbersome calculation. So to make life easy, we have a table. So this is a guide for adrenaline infusion. As described earlier, we'll dilute 0.5 ml of 1 is to 1000 adrenaline in 500 ml of NS, which will give 1 microgram per ml dilution. And this has to be continuously infused starting from 0.1 to 1 microgram per kg per minute. So for example, if the patient's weight is 20 kgs, and if we are going to start it at 0.1 microgram per kg per minute, so it will be 2 ml per minute. So that means it will be 120 when we infuse at the rate of 0.1 microgram per kg per minute in a 20 kg child. So uh, the dilution we have prepared, that should be taken 120 ml should be infused over 1 hour. And likewise, we can titrate it up according to the. So other adjunctive therapy apart from adrenaline. So usually these medications comes to our mind whenever we are thinking about treating a case of anaphylaxis. So the take home till now is you need to think of adrenaline first and then come to adjunctive therapy like H1 and H1 blockers or H1 antihistamine like phenylmine maleate, which comes with the trade name of Avil. 1 ml contains 22.75 milligrams. In pediatric age group, we give 0.5 milligram per kg IV every 8 hourly. H2 blockers, ranitidine should be given 50 milligrams IV in case of pediatric age group, 1 milligram per kg. And glucocorticoids like hydrocortisone can be given at the doses of as high as 200 milligrams IV in pediatric age group. The dose is 5 milligram per kg. But you need to remember that these are adjunctive therapy and these should come later in your mind. But whenever you are in a team, one of the team member can start adrenaline, and at the same time, the other team members can prepare these adjunctive therapy.
Yes, that was very important point. So adrenaline, IM is the main treatment that we should start. So now let's go on to the case. So we have started adrenaline, IV is open, you've given IV fluid, there was bronchospasm, so you started subdermal nebulization and magnesium sulfate infusion was given as recommended. And then you also started adjuvant therapy with hydrocortisone. Patient has improved and very happy. The bronchospasm has improved, the shock has improved. So now, how would you dispose the patient? Okay, patient is wanting to go home. What would you recommend? So you can pause the video and on pause when you are ready with the answers. So here is the guidelines So if the patient had refractory anaphylaxis, which Anmol had talked about, if the patient needed some airway intervention, right, then ICU admission is warranted. If patient had life-threatening problems, as I've mentioned earlier, like bronchospasm or shock, then uh, admission for observation in ward is required because there may be biphasic reaction. And if patient didn't have any life-threatening problems, you still have to observe for at least 6 hours because patient may have biphasic reaction within that period. And if we have planned to discharge from the ER, appropriate instruction on what allergen to avoid in future, what to do if something happens in future, when to return to ER, and you should discharge the patient on oral prednisone for a few days. It's 5 6 days and antihistamine.
So by now, we hope that you have learned how would you be dealing with cases of anaphylaxis. So we hope the learning objectives are met. So we identified the clinical signs and symptoms of anaphylaxis, and we also outlined initial management of anaphylaxis.
Um, and so this is the protocol for our emergency department. You can find it in emergency ward or on online also. So everything that we've discussed earlier is here. So first thing is diagnosis, and then ABCD approach, removal of allergen, and then first identifying whether there are life-threatening problems. If yes, as you can see, adrenaline IM is the first and foremost action, which should be followed by initial stabilization, management of airway, which can be very, very difficult and fearful, management of bronchospasm if it's present. And we watch for resolution and repeat the dose of IM adrenaline if required. If we have refractory shock and patient is in circulatory collapse and not responding to IM adrenaline, we go for IV adrenaline infusion, which can be very tricky and which can itself cause some complications. So always consult your seniors and be very vigilant for that. And here comes the adjuvant therapy at the last. Yeah. Yeah, this is it. This is actually theory, and we would have more interaction if it was done synchronously with you. But then, due to COVID times, so this is what we prepared. After this, I think you'll get some insight about anaphylaxis, and we'll be ready to manage the patient in future, and you'll be able to save lives. No patient should die of anaphylaxis. We should be very vigilant and we should be very fast in our treatment, especially IM adrenaline should be given instantly. There is no side effect of IM adrenaline, even in old age or even for those who have heart disease or anything. So let's save lives.
Thank you.
Thank you.